Well, welcome back to the podcast, everybody. I wanted to give a special shout out before we introduce Sadie to Intellicom Consultant. This is their studio. They're letting us use this for anytime I need it. Also want to give a shout out to Crumdale Specialty as well, the good folks over there. Today we're tackling one of the most complex and expensive areas of your health plan, pharmacy benefits. I'm joined by Dr. Sadie Mannino Bennett, a board-certified pharmacotherapy specialist and second-generation pharmacist as a part of the family behind Mannino's Family Practice Pharmacy, a full-service community pharmacy that has been serving Louisiana since 1983. Sadie brings a unique perspective. She's not only a clinician, but also someone deeply involved in the operations of an independent pharmacy. She's seen firsthand how pharmacy benefit managers, PBMs, drive up costs and reduce access, and how local pharmacies can be a part of the solution. In this episode, we'll dive into what most employers get wrong about their pharmacy pricing, how PBMs profit behind the scenes, why local pharmacies are a strategic asset, not just a convenience, and how you can design a smarter benefit plan that actually supports your workforce. If you're a CFO, HR director, or CEO looking for ways to cut waste and improve care, this episode will give you real insights and practical next steps. So, Sadie, give us a little brief introduction on yourself and your background.
First of all, thanks for having me. Like you said, I'm a doctor of pharmacy, and I am a board-certified pharmacotherapy specialist. It's an extra board certification I choose to have just to benefit our patients and further my knowledge in pharmacy. I went to undergrad at LSU and then also did a year at Southeastern, worked as a pharmacy tech in my father's pharmacy, and then went to pharmacy school at Xavier, University of Louisiana in New Orleans.
So let's talk about the pharmacy. How long y'all been in business? Your dad, what's his kind of background?
We've been in business since 1983. We are a Joint Commission accredited pharmacy, which is very rare. Pharmacies are not required to be accredited by Joint Commission. Usually that's only for the hospitals and big organizations. But we chose to do it, or he chose to do it so many years ago because, again, felt like it was a good standard to have for ourselves and for what we do for our patients. We're considered a combo pharmacy, so we are a retail pharmacy. Of course, we fill prescriptions for regular patients, but we also service long-term care facilities and hospices. We also do non-sterile and sterile compounding, and really anything you can think of other than nuclear. That's really our only thing that we don't do. That's a whole other specialty.
One location?
One location in Hammond, Louisiana. Yeah. And,
Where would you say most of your business comes from, the Hammond community, or do you get some outsiders coming in? Or?
We do get some outsiders. We service a lot of just the general North Shore area, anywhere really from Baton Rouge to the Slidell area.
Mm-hmm. I want to start off with some ground rules. We're not going to mention any large PBMs. We're not going to mention any carriers. We're just going to try to support a local pharmacist. So we're not going to even talk about the large pharmacy centers out there. But as we're talking about how you exist in the community and the other pharmacies that we all know and recognize, what's your message to your population of like why you exist in the community?
Oh, well, I mean, the biggest thing is we know our patients. And I think people don't realize, I think, that a pharmacist can and should be a part of your care team. You know, you pick your doctor who you see and you follow up with, and your pharmacist can be just as integral in your care. And we are. That's what we do for our patients. You know, we've serviced our area for as many years as we have because we take care of families, you know, young and old. We grow up with you and help you as you navigate through your health as you age. That's what we take care of.
Yeah, that's a good point. I always say is like I don't want to be at a grocery store at a baseball game or a football game and see one of my clients and they're like, oh, I'm dealing with a problem. And that's your kids are in the same area with a lot of your patients. And
absolutely.
You want to be able to say, look, oh, we helped them out with a drug that was very expensive that we got elsewhere, or we helped coach them on how to work with their insurance.
Yeah, it's interesting you say that in particular. Growing up, I think one of the reasons I became a pharmacist is because, I'd be at a football game in high school and a random person would stop me and they'd say, oh, you're Sadie, right? I'd say, oh, yeah. And they'd say, your dad helped me with my kid's XYZ disease. You know, no one else could help us, and he made sure we got what we needed, and he took care of us. And so we'll forever be grateful and we'll be patient. And that was a really neat thing for me to see how much a pharmacist could impact people. And that's why I became a pharmacist.
That's interesting because I'm young. I have 2 kids, and we don't really have any needs for pharmacies besides like antibiotics and things like that yet. But our videographer, Alex, was literally talking about this. He's behind the camera, but how the frustration you deal with large pharmacies and you can't get people on the phone or you get to run around, and having a real person you can call. And that's why people work with people like me and Telecom and you, because we're real people in the community and we can service your needs. But people want that in today's age. And they're frustrated with the insurance companies too because they're getting run around about.
Oh, yeah.
Then talk about wasn't there a law that, like a whistleblower law, where you couldn't tell patients about certain access to drugs, and now they kind of changed that.
Yeah, so actually, my dad worked really closely with a reporter in the area on that. You've seen, I'm sure, reports where people are behind the cloak and it's dark and they distort their voice and things. And he worked really closely with, like I said, a reporter on that, and talked about a lot of different things that we see with PBMs and in particular some clawbacks that were happening on that are now illegal on prescriptions. And in all of that work, laws came out that also allowed pharmacists to be able to discuss their plans with patients. And they were called gag clauses, and we weren't allowed to discuss anything about a patient's plan with the patient, or we'd be in violation of our own contracts and risk being kicked out of network. So that was a big deal. It not only got passed in Louisiana, but also federally. So now pharmacists can, in fact, talk to patients about their plans.
Yeah, because I think about the guys like Mark Cuban of the world that's making his cost-plus drugs popular and GoodRx's, and people are seeing all this stuff, but then they go to someone like you, and like you know about it, and it's like, I know the secret, but I can't tell you about it because it's going to affect my contract here. What's your opinion on all these coupon codes? You think it's helping your business, or is it like, especially like Mark Cuban? Like, I think he's a voice for people like me and you. Now he's got a different perspective than us and different financial reasons behind it, but it's drawing some light on the pharmacy community a little bit.
Absolutely. I mean, a lot of what he says is very true, very accurate. He sees a lot of what we see. I think as far as like the coupons, the GoodRx's and things, I think that they have a little bit of they have their own goals and profits they're trying to make. A lot of times they charge us fees to try to use those coupons. They're not actually cheaper than a regular cash price for a lot of the drugs that we do. And a lot of times it's just not worth an independent pharmacy billing for, like I said, maybe a brand name drug that maybe it does help out with some costs for the patient, but it'll charge us so many fees it's not profitable for us. So it's not something that a lot of times independent pharmacies will dabble in. Of course, we'll always try, but it's just not something that's really built for us. It's more so the bigger the chain pharmacies and things.
Are you open to that with your patients and saying, hey, look?
Oh, yeah. I'll tell them, absolutely. Look, they're going to charge us this fee and we're going to lose however many hundreds of dollars, and unfortunately I can't do it, But I'll be happy to help transfer the prescription wherever you want it. Just tell me where to send it.
And I think that's fair. I mean, I'm just thinking about the things that I pay for in my daily life, and I just want someone to be honest with me. It's like go and take your car and like, hey, man, you really should go here. Like, this is not my expertise.
Right.
Like, go here. And it's because like it's going to cost me more to do your work than it's actually worth. What are some hidden costs that you're seeing in your space that people need to be aware of? Maybe go into like how rebates affect you and that.
I think first it's important to understand what is a real cost, an actual cost of the prescription. So when you talk a prescription cost, you're talking about, yes, the cost of the drug, but usually we talk in terms of cost plus dispensing fee. So dispensing fee is usually what encompasses the pharmacist, the bottle, the label, the computer software, the lights of the building. Actually, the state of Louisiana is really good about every couple of years they do an audit, and we all turn in all of our costs for everything. And they come up with a number, and they determine that in the state of Louisiana, it costs $11.81 to fill a prescription. So, like for all Medicaid plans, they are required to pay NADAC, which is the National Average Drug Acquisition Cost. So the national average of the cost of the drug, the true cost, plus the dispensing fee, which is $11.81. And that's probably considered a fair reimbursement. Also, maybe not, because if we're truly just paying cost plus cost, that doesn't exactly leave us room for profit. But, it's a lot more fair than some plans that genuinely you'll bill a 30-day supply of medication and they'll pay a total reimbursement of 42 cents. I mean, you can't run a business that way, but unfortunately we see that a lot, especially these older, cheaper generics. You see that a lot. Or sometimes you bill a medication and they'll genuinely pay you below cost. I mean, if I pay, say, $1,000 for a med, maybe they pay me $800, maybe they pay me $850, maybe they pay a dispensing fee and maybe they don't. So a lot of times when we talk drug costs, you have to kind of decipher, are we talking about the drug cost? Are we talking about the total reimbursement, dispensing fees? Because sometimes it just makes a difference at what you're looking at. And that's
how many employees do you have in your operation?
Employees, we have about 11.
11? Mm-hmm. Do you have someone that's dedicated to like insurance? I call them operations manager, or somebody that's like that's a full-time job. It's
really a full-time job. We don't have one person that does it full-time, to be honest. Ricky and I, my dad and I, primarily are the ones that are looking at that. Every pharmacist and tech, really, every time we bill a claim, we can see immediately the adjudication of what's supposed to come back from the insurance company or the PBM. And immediately we can determine if it's a loss or a profit or what we're going to do at that time. But as far as like the large, broad strokes, Ricky and I mostly handle that.
Because I'm thinking, I want to talk about DPC for a second. A lot of doctors are starting to go down the DPC trend because they don't want to deal with insurance billing. That means they had 10 staff members because they needed that for insurance purposes. Well, we can just go doctor, office manager, cash pay, DPC. We don't have to deal with any insurance billing. And I'm just thinking about, like, we're all trying to run a business. Like, my business is my brain and my computer and my carrier relationships. Your business is all that stuff you mentioned that is very complicated, and you're getting reimbursed 42 cents on a drug. Like, the lights, like, my energy bill is $600 this month because it's hot in New Orleans.
Right.
Like, but in the winter, it's going to be $200. Like, you have to kind of budget for that throughout the year. And thankfully, my revenue is pretty stable, but your revenue is all over the board because you're losing money on one drug. But let's just say if you have a patient that's got 5 drugs and you're like, okay, 3 I'm making profitable, I'll take the 2 losses.
We 100% do that all the time.
Yeah.
We do that all the time. Look
And
at the patient as a whole.
That one person's got a spouse and a kid.
Right.
So from a community pharmacist perspective, it's like, oh, the Burgess family, we lose money on Mr. Justin, his wife and kids were good. I don't want you to think like that, but that's
we
how
do
you
all
have
the
to
time,
think.
though. We do it all the time because we do want to take care of people, and we do want to fill their prescriptions, and we do want to be part of their healthcare team. So, of course, those are things that you look at, and you can't. We don't want to lose a patient over one drug. I mean, that would be absurd. But so of course we factor those things in. Yes.
But that also could lead to a conversation with their doctor and say, hey, look, I think there's another drug that you can prescribe that's going to do the same thing. That's less.
Yes, I mean, sure. I don't love changing therapies just for a cost perspective.
That's a good point.
And a lot of, especially patients are stable and this sort of thing. But I mean, certainly could it open the door, especially if the patient. A lot of times patients will bring suggestions or things like that, especially if we're explaining, oh, we're losing money on this medication, we can't fill this one, that kind of thing. A lot of times they'll say, well, what are my other options? Especially if they're just starting a new drug, that kind of thing. Sometimes that'll happen, but I wouldn't say that that's something we do regularly.
Yeah. My recommendation to people is, like, if you're going through an expensive drug or something, there's a support group out there that people have gone through the exact same thing. So use the internet. I forgot the name of the drug, but it was a mom that had a child diagnosed with something crazy drug, and I'm literally on the phone Googling with her, and I found this, like, mom support website that was for, parents with this specific drug. And, like, one lady wrote down everything. And I'm like, that's our plan. We have to go see if we can get the carrier to approve this, and this, because this is approved and not the drug that your doctor. And, I think doctors are just doing their job. But that's why I like the DPC trend, because the big docs in a box, they don't have the time to have a really conversation with you. Versus a DPC doctor, like, that's their job.
Right.
And they can have more of a care conversation with you than a 10-minute computer conversation. And, like, I switched to a cash pay doctor because I'm fed up with my doctor, like, doing this and, like, talking to me like this. It's just not a real warm and fuzzy feeling. And we shared my personal story before this. I lost 70 pounds on Mounjaro, tirzepatide, and I got started because I went to a doctor at a big name hospital system. They didn't give me any attention. They said, go to a urologist, and it was a 3-month wait. So I'm like, okay, let me just go to a cash pay doctor. Got my blood work. My testosterone was low. Everything was low. Big box doctor wouldn't do anything for me. They're like, eat healthy. This doctor's like, hey, we have this new thing out here that's not really 100% tested, but we think it's going to work. It worked. I'm perfectly healthy right now, best shape of my life, mentally, physically. But it's because one doctor gave me a chance to just tell what my symptoms are and gave me feedback. And the other doctor was just 30 patients that day.
Right.
And
absolutely.
And
I'd argue that similar things happen in pharmacy all the time. I mean, how often do you get to actually talk to your pharmacist and spend time with your pharmacist too? And I think that's one of the things that an independent pharmacy can bring to you, is that you get to actually talk. We ask patients all the time, well, okay, so, not only, what are your lab values, or do you know them, or, what's the doctor telling you? And from there, we're able to build conversations with them about more drug-focused conversations, but also life conversations. And how can we better your health overall, whether it's drugs, vitamins, nutrition,
electrolytes,
everything. I mean, we do all that. And I think that is a big value that we bring, is being able to talk to the patients.
So I'm a big internet guy, and I'm on Reddit all the time. And there's a health insurance subreddit, but people are figuring out that they can put their blood work into ChatGPT and say like,
Oh,
"Tell
interesting.
me I'm a doctor, give me a recommendation," because they don't have someone that's like giving them advice on like what to do. And I actually had a company, BioLite, reach out to me, a little electrolyte packet, but she's competing with the other brands. I won't mention those, but her dad was a doctor, and he built an electrolyte drink for her mom that had cancer, and I was like, I want to work with you because I'm like, you built a company and a brand off of a real thing that happened with your mother, and you're building something that like, hey, Justin, you need to drink more electrolytes through your day. That's why you're fatigued and
Right.
other things. But like, you would tell me that if I just come and be like, oh yeah, I've been taking this medication and I feel lightheaded, dizziness, and just not feeling good.
Absolutely.
And
then,
that's just normal conversation as I'm checking out with my kid.
yes. And even things, okay, so you're on this medication prescription, and it can be known to deplete B12. Are you feeling really tired? Are you having trouble? Maybe you need to take some B12 over the counter too. Little things like that you may not get when you're not directly interacting with a pharmacist, are things that we do all the time.
And I'm just thinking about my experience at the big shops, and you 10 people in line, people are overworked. They're nice people. I just think they're in a phase of life
Yes.
that it's out of their control. And maybe
Yes.
they don't have opportunities to get jobs at companies like you because there's not that many that exist. So they have to start somewhere. And ironically, a lot of the people that I work with on the PBM side started off at the big chain places. And that's a good career progression because I need people so the folks at Crumdale, like they have a full pharmacy team. Like there's some really smart people that we can start rattling off drugs. They know everything that you know that I don't know just yet. But they worked at the big shops as a pharmacy tech when they were 25 out of college. So I think it's a good experience ground, but
They just don't, they're not allowed to see a lot of the things that we see. When they bill an insurance company, a lot of times they're not seeing all the same numbers that they really don't. They're blinded to that in a lot of cases. They don't get to interact. A lot of times you'll see the pharmacies are designed where they have one counter with the clerks, and then behind that counter is where the pharmacist is. And so you're further away from them. Whereas our counter, you can walk right up to me anytime you want. Or you can call, ask for me, I'm going to pick up the phone. And it's just a different, I do believe pharmacists, I'm proud of our profession. I do believe they all do a really good job of taking care of patients to the extent that they're allowed to. I think it's just a different model.
Yeah, and I want to mention some things about like my world. So like I'm in sales. That's my goal, and a lot of companies don't want people like me talking to my clients or employees. But I see the value in like Friday, late Friday, my group in California texted me and said, "Hey, this person's having an issue at the pharmacy." I call them like, "Hey, what's going on?" And like I build a rapport with that client and that employee. So next year I can be like, "Hey, you had any issue?" "Oh no, we're all good." Like, and so I think like the industry, or this is most industries as a whole, it's like your people at the top like me and you, like we see value in doing the extra work like that because we want to build rapport. But as a whole, people want our support staff, we call them account managers, I'm sure you call them techs. Yeah, you want them to get experience in having those conversations, but like me and you are once that person, and you miss that like human interaction of like fixing something real.
Yeah, we just, that's a lot of what we do.
Our brain's wired differently. Like as much success as I think I've had and will have in the future, I don't want to lose the human side of my business.
No, I mean, I think I've always thought healthcare, from my perspective, healthcare is really the people. Yeah, we have a lot of these systems that are built and these big systems, but when you get down to it, like you're talking about, you want to talk to your doctor, you want to talk to your pharmacist, whoever it is, your person that's taking care of you, your nurses, whoever they are. And that's really where you get your good outcomes is the people. And so, I've always wanted to, and I think my dad's done a good job of it. That's hopefully my plan is to be someone that's involved in the care forever. Yeah.
Well, we talked about the Mounjaro, tirzepatide, Ozempic, Wegovy, Zepbound, whatever you want to call it, semaglutide. Talk about when you first got introduced to that drug and how it impacted your pharmacy, and talk about the costs from your perspective and how you're losing money on the drug.
Okay, so when the drugs first came out, in particular the Ozempic and the Mounjaro, there were other drugs in the class, because remember they started out as type 2 diabetes drugs, and so they were an extension of those drugs, but these seem to have better weight loss associated with them. The other ones had a little bit, but these had some better results for that, which of course a lot of our type 2 diabetic patients have a weight problem, and so these drugs had an added benefit for that. very quickly, the PBMs, though, made it clear that, they were going to audit these prescriptions because they're high cost. And upon audit, they were going to want every patient to have a diagnosis of type 2 diabetes. And if they didn't, then they were going to take the money back. They were going to consider it fraud or waste or abuse or one of those. And upon audit, say it was inappropriate for us to fill and take it back. So we pretty early on were aware that that was how it was going to be. And we were only able to fill them for people that had type 2 diabetes. And it was written on the prescription, or we would call to verify the diagnosis from the providers, because as quickly as they came on, I would say the PBMs pretty quickly came on with their approach to how they were going to handle it, and they made it very clear. So there were a lot that we didn't fill for patients that probably could have benefited. We use drugs off-label all the time, meaning that we use them for what they're not necessarily approved for, but it works just as well. Like technically, one of the best drugs for nausea, Zofran or ondansetron, it's only indicated really for pre-chemotherapy nausea prevention, okay? But we use it all the time when people have nausea actively, okay? And technically that would be an off-label use, but that's just one example. We do it all the time. We use drugs off-label. And physicians have the right to prescribe it, and pharmacies have the right to fill it. But when it becomes an issue of cost is where it gets a little dicey, because should an employer and be paying out all this money, or an insurance company be paying out all this money to cover the cost of a med that is maybe not indicated? It just becomes a debate. But so there were a lot that, like I said, that we just didn't fill because it didn't have the proper documentation, and we couldn't, because you can't fill a script, an expensive script like that, and then the insurance company is going to come back and take all the money. You can't do it. So unfortunately, we weren't able to do it. And then even the ones that we did fill, and even now, the drug costs about $1,000 plus or minus, and sometimes you bill it, and the insurance company or the PBM will come back and the reimbursement rate is maybe $800, maybe $850. And you can't fill a med like that. So again, we'll just tell them, look, unfortunately, the reimbursement is below cost. It's a significant loss. We can't fill it. And we're happy to transfer it out to whatever pharmacy you want. A lot of times the big boxes, they'll still fill it. But, it's not something we can do. And a lot of times patients understand that. We hate it. We really try to avoid that as much as we can, because we do want to take care of people. But, you got to keep the lights on, too.
But she was telling me before, you have to have the cash to buy these drugs too.
Oh yeah, you have to buy it before you. And the insurance companies, or the PBMs, they're required to pay us every 2 weeks, and theoretically, it's going to encompass all of the claims from the past 2 weeks. It doesn't always happen that way. Sometimes you're waiting for your money for some of these claims, 6 weeks, maybe longer. Just kind of depends on the claim and the processing time for that claim. And so you're constantly working. And by that point, the patient's due for a refill. You filled it a month ago.
Yeah.
So now you're putting out even more, right? So those numbers aren't great, but it is the business of pharmacy. It is.
Well, speaking of that, let's talk about Arkansas.
Okay. Yeah, Arkansas. So Arkansas is probably one of the best states as far as regulating PBMs and trying to really help contain this whole system. They recently passed and signed a law that you can either be a pharmacy in the state or you can be a PBM. And you can't be both. And a lot of these PBMs, they own their own pharmacies and steer patients towards them, even though that's illegal. And they do it under the guise of saving money, and it really doesn't save anyone money in practice. I'd love to talk about that. But so the state of Arkansas said they can't do that. So one of the large chains that owns both, they decided to close all their pharmacies in Arkansas because it's more profitable to be a PBM than it is to be a pharmacy, even when they're paying themselves an inflated rate. Isn't that interesting?
So we were talking about the vertical integration, which everybody on my LinkedIn has seen a version of this online. It's the integration between every insurance carrier, PBM, and all the different verticals and how they're paid. But it's crazy when you pull back, like she just said it, that they're paying themselves, but it's cheaper for them to just close shop and just be a convenience store at the end of the day. Mm-hmm. But that's when I literally made a post. There was a pharmacy convention probably about 2 years ago, and I made a post online, and I got 2 pharmacists reach out to me because they were in town for that convention, and I didn't understand, or I just wasn't educated that y'all lose money on drugs, and I'm just like, how do you operate a business like that? And it's eye-opening to hear the large the big chain, large employer make the decision, like, we will happily take a loss versus you. It's like, I can't take a loss on that. And that's frustrating to me because, like, you want to help your patients, but you're running the business.
So the state of Louisiana did make it to where it's illegal to pay us below cost. That started this year. In practice, it still happens. We can file appeals to the PBMs and the insurance companies and get it brought up to true cost. So again, we're not talking profits, we're talking true cost. And however, you have to file it every month. It doesn't happen going forward. So every month you're having to do this paperwork, and it takes a long time. And now you're taking time away from patient care. And sometimes you just don't do it, I'll be honest. Now they're trying to close that loophole. Actually, right now there's some new legislation they're trying to get approved to where that can't be done and all, but it does still happen.
What's your thoughts on international sourcing? Are you...
Well, I just think that drugs should all cost a fair price. Drugs in America, if you actually look, they cost way more than they do in other countries. And they're all produced in the same places. There's a Hep C drug here that we all use that in America it costs about $50,000 to $80,000 for the full course of treatment, and in India it costs $900. Okay, and I guarantee you they're not losing money selling it at $900 in India. Drugs. The problem in general is that our system is built to allow for high drug costs because they also build in the rebates, and then they allow for all the greed. It is what it is. So if drugs here cost a fair price, a lot of what we're talking about would go away. But also you got to get rid of the rebates, and you have to charge a fair price for the drugs, and then you'd finally have a system where you could really honestly talk about what are the real costs.
So my competition, the big brokers of the world, talk about how their contracts with the PBMs are the best and they get the largest rebates. But my argument is screw the rebates. Let's find the lowest net cost.
Yes.
And we'll get out that game completely. Mm-hmm. But people's always said this years ago, and no one got fired for picking IBM when it first came out. Mm-hmm. And people are afraid to make that decision to go with a Crumdale specialty that uses Welldyne Pharmacy or a Smith RX because they... I've never heard of them, mm-hmm. But you never heard of Intellicom, and they're a large, massive company. Doesn't mean they're not going to do a good job for you. And mm-hmm. people are so bent on I need to work with a large PBM because comfort or just large rebates. And
yeah, it's interesting. So the rebates, I think a lot of people still don't understand how they work. So I buy the drug, let's say for $1,000. So I bought that. Let's say the insurance company pays me $1,050. Okay, so let's say I made money in this instance. Well, so they've paid me, and they're going to bill the PBM is going to bill the insurance plan for their portion. So say they bill them, I don't know, $1,200, $1,500, whatever they're deciding to bill the plan, right? Meanwhile, on the back end, the manufacturer is going to give their rebate to the PBM, and they're going to pocket that. Sometimes they're good about passing the rebate on to the plan. We're talking rebates. Sometimes they're as big as 60, 70%, the list price of the drug. I mean, they're gigantic. And they get that for every fill. And maybe they pass it on to the sponsor, maybe they don't. But then they've also got this new thing they do, the GPOs, where the manufacturer has to be a part of that as well, and they'll charge them fees. So maybe the rebate's not as high anymore because they're having to pass that on, but those fees get higher. And since they're a fee that's technically paid to a different subsidiary under the same umbrella, they don't have to report that. It's not the same thing. And they get to keep it all. Because you'll see a lot of times now they're putting regulations on the rebates and things, but I know you said that the rebates don't always get reported to the plan sponsor.
I'll give a shout out to Dean Jargo at Fair Market Health, but we're doing cash pay for physicians and knee surgeries, and it's all in the preface of we can negotiate with the doctor on a cash pay basis because we're going to pay them in 24 hours. Mm-hmm. We're going to know what it is ahead of time, and we're going to incentivize the employee and say, hey, Justin, if you're willing to go down this cash pay route, you have a $5,000 deductible, we're going to waive it to zero.
Oh,
because we know that if we go through insurance, through a network, it's going to be $60,000 for that knee surgery, and through our cash pay, it's going to be $20,000. We also know the quality score of the doctor as well, the readmission rates, infection rates. So we can say we're not sending to a doctor that is less care and less lower quality. We're sending you a high quality doctor that charges a fair value for that service. And it's the same model. It's if that doctor does 100 knee surgeries a month, he's very good at it. He has all the supplies. He doesn't need to charge a bunch because he's got 100 every month. But the guy that does maybe 3 or 4, probably not as good, probably charges more because he needs to make more. He's not doing 100 a month. So these cash pay systems and tools, it goes back to education. It's like you need to educate your employees on the front end to use the resources like you and cash pay and me. But at the end of the day, we're just trying to provide tools and resources. And what you're doing for people like me is that you're actually talking to your patients when they're at the time of visit versus like I'm dealing with a lot of stuff retroactively.
Right. That's interesting.
Because the problem in healthcare is most people go and get services done and don't realize what it costs. So we need to flip the script and say, find out what it costs, then go get it.
Right. Right. No, it's and there are unfortunately some things that are just expensive that might, if I'm buying a drug for $1,000, I mean, it costs $1,000. It's just an expensive drug. So there is a role, of course, for some cost sharing, but it's a matter of, what's fair. Yeah,
and I'm a fan of international sourcing and mail order drugs, but like I don't want that to be the solution. I want the employee to have access to go get it where they want first.
Agreed.
But if we can't get it there because of your unwillingness to do it, because of your business reasons, and they don't want to go to a big chain shop, we'll go mail order. And
but see, what's interesting though with mail order or with the pharmacies that are owned by, if you looked into, I'm sure you've seen it, like the FTC, they're really investigating a lot of this, and they've had 2 interim reports that have been released. And so, like in theory, economies of scale, these chains and these large mail orders, they're getting things cheaper, and so they can do it cheaper. Okay, that's the theory, but in reality, that's not what's happening. If you look at all those reports, you'll see that a lot of times up to 1,000% the cost increases as they're reimbursing themselves via mail order or their own pharmacies. I mean, the numbers are very significant. And so it just doesn't translate in real life. No one's costs go. Yeah, even plans that go to mail order consistently. I mean, year after year, those plan costs increase. They do, and we've seen it. So this really happened. Like I said, we service long-term care facilities. This example probably happened about 15 years ago or so. But so we had 2 patients in the same facility, same doctor writing the med, same medication, same directions, everything. Okay, identical scripts. You bill the patient that's been there for a while. They reimbursed us a number. Let's say, I think it's something like $4 for the drug and maybe $1 for the dispensing fee. Okay. Then we bill the patient that just got to the facility. It's the first time we're filling it for this patient. We bill the same drug, same everything. And they suddenly only pay like $2 for the drug, but the dispensing fee went up to $150. Oof. So we called, because that's wrong, and we know they're going to come back and get that money from us anyway, so we called. And the pharmacist that spoke with the PBM, long story short, they said, oh, well, that was reimbursed on the mail order contract. We're like, well, we're not a mail order pharmacy. And what happened was before the patient entered the long-term care facility, they were on a mail order contract. And so they were getting all their meds from a mail order. And so when we billed it, the computer didn't recognize that we were a different pharmacy, and it immediately paid us at that higher rate. And so, what's really funny about it is, in good... They probably said, oh, well, we save on drug costs. And they did. They paid us less on the drug, but they inflated the dispensing fee to $150. We still have the paperwork on it. It was unbelievable. And of course, they took the money back. They realized it was an error, blah, blah, blah. But that is an example right there and then that shows you it doesn't save you money, really, by going to those mail order pharmacies in a lot of instances. And it's because they not only pay themselves and now you're seeing, too, again, if you go through those reports, you'll see that a lot of times they not only pay themselves more in the dispensing fee, but also a higher margin on the drug, significantly. But, patients say, oh, my copay is $0.
I don't care. Yeah.
It doesn't matter. Your plan is going to pay that large inflated amount. They're going to make a lot of money, and your premiums are going to keep going up.
So that's what I'm doing for folks is that we're doing a PBM analysis where we're getting all the drugs and we're running it through multiple different systems. One of the vendors that I use is called GoGo Meds, Trace over there. We're very close. I was actually talking to them last night. But they actually started off in the veterinary space and flipped to employers because they're working with some other companies that I don't want to name drop, but very big mail order type pharmacies. But he can source drugs for me for like pennies. And we're getting billed like $30 from our PBM. And it's just my message to all employers out there is just get access to your data and start doing this. Then you'll see that like, oh, the drug's here, priced differently. You don't want to force everybody to a mail order situation because I don't think it's the right thing to do. But if you tell them like, hey, you're getting it priced here for X, here it's going to be a lot less. And I'm frustrated with like my group in California specifically. Let's say the average salary out there is $45,000. They live in California. They get taxed very hard. Mm-hmm. I'm sticking with them with a $300 a monthly premium. Then they got to pay hundreds of dollars for their drug every month.
Right. Mm-hmm.
It's how do you afford to live? And people are making the decision of like, I don't really need this drug or I can't afford it. Mm-hmm. So if there's tools and resources where I can give them maybe free generic drugs through this program, and I'm helping on the specialty drugs because if we source it internationally, we can maybe get the price down to zero, or a patient assistance program where we literally take the drug off the plan completely. We just help the employer and the employee because we're saving the employer a ton of money. Like Humira, that we had one for $52,000 that was on the plan. We switched to a biosimilar. I forgot what we saved them, but
Absolutely.
The employee got the drug, the employer got the savings. That increase next year is not going to be as so high. Then the other thing to consider with the rebate game is that fully insured carriers don't give you any credit for your rebates. So they're looking at your claims. They know about your rebates, but you don't. So they're going to say, okay, you have 4 top drugs that are $500,000, Humira, Simponi, all these other ones, and we got to give you an increase to justify it. But they don't tell you that they're making
60 or 70% of that
on the back end.
On the back end, right?
Well. Right. I want to end it with something that just your message to your members of your community. Mm-hmm. You have employers out there that, obviously have employees that go to you, but what's your message to the community?
I think ask questions. And I would really recommend for patients, make a pharmacist a part of your care team. A pharmacist can help you with your health. It can help you with your insurance plan. And they really can be an asset to your whole team. I mean, I can't tell you how many times we consult with doctors, we catch errors, only because we knew the patient. We knew what their disease states were, what other comorbidities they have, and you catch errors that because the system is so computer-based and built, just errors happen, and your pharmacist can solve that, especially if they know you. They'll catch a dosing error based on different things. They just will. And then on the plan side, I would say, again, talk to your pharmacist, especially if you're working with an independent pharmacist. For example, we had a hospice that we worked with very closely. And a lot of the independent pharmacies in the area were billing them directly. And it was all the same contracted rate. That's what we were all doing. They wanted to go to a PBM. It said that would make their life easier, and they thought it would be cheaper. Okay. So we all agreed to do it reluctantly. And after a couple of months, everybody else actually said they were getting out. We were all talking to each other. They're getting out because, everybody's losing money. So my dad, Ricky, was the one that actually called the director of nursing and was like, look, let's talk about this. Like, we want to keep taking care of you, but the numbers aren't working. She's like, well, give me an example. He says, okay. So we filled a lot of morphine for hospice patients. It's very common. And at the time, before the PBM, we were probably charging the hospice, it was about $14.50. Cost was about $10, okay, at the time. And but we started going to the PBM, and they were paying $10.50. Okay, so now we're only making 50 cents, and you're looking at the whole picture. Okay. And she's like, no, you're not. She's looking at her number. She says, no, you're not. I'm paying $27. And she says, exactly. You're paying $27. I'm getting paid $10.50. That hole in the middle is what you're missing. And so if you can get your hands on numbers like that, talk to your pharmacist, talk to anybody you can to really kind of dissect that, break it down, what's happening. Then you really get some insight into what's going on and what you're paying for.
Well, thank you. My message to employers out there is that, look, we have people like her that work for the PBMs and the transparent PBMs that understand exactly what she's talking about. Is when you're vetting your PBMs, there's third-party consultants that will actually vet all the PBMs for you from a contractual perspective and also a clinical perspective. But get access to your data, do the research, work with people that we're not financially motivated to in the other areas of like making a lot of money on your plan. We just want employees and employers to know where the money's going. And once you figure out the incentives, you know exactly where all the money's going. So I've seen some plans where brokers are getting paid like 50 cents per script, and it's disgusting. I think that, employers need to work with consultants that are transparent and honest through the entire process. Mm-hmm. All your contracts with all your different vendors are transparent and know how every part of the supply chain gets paid. And it's exactly if you work with folks like in telecom or any other part of your business, your copier, you're going to know what the contract is. You're going to know how they get paid and how they're incentivized. And unfortunately, we're in an industry where people don't know that. So we're trying to uncover all that for people and just give them the tools and resources to make smarter decisions. So that's it. Well, thank you.
No,
Appreciate it.
thanks for having me.